Hi dear friends, myself Dr. Vinod KV, consultant urologist in QR and SK Hospital, Trivandrum. Greetings to all of you from Kerala, which is the southernmost state in India. Welcome to my video on Sheathless RIRS. Here I am sharing my experience on this procedure. Access sheaths are an indispensable part of standard flexible ureteroscopy. There are many benefits for its use. Introduction of flexible scopes into and out of the kidney becomes easier. They provide easy drainage of irrigants out of the kidney. And access sheaths helps to maintain the intrarenal pressure within the permissible limits, which helps in reducing the incidence of postoperative sepsis. These are the main reasons why we love to use access sheaths during a flexible ureteroscopy. But there are also many problems secondary to the use of access sheaths. Access sheaths can produce ureteric injuries. The injuries can occur during its introduction into the ureter or during the procedure due to its movements. Keeping the access sheath inside the ureter for long duration can also cause ischemic injuries. Ureteric strictures are the price we pay for these injuries. And larger access sheaths need to be placed so that we can pass flexible scope freely through its lumen. This often necessitates preoperative stenting, adding to the morbidity. If you are doing a primary case, we need to have overdilatation of the ureter. And most of the access sheaths are disposable and cannot be reused, and this adds to the cost of the procedure. Needless to explain the little discomforts we face, like additional time needed for its secure placement and its displacements or slipping, which necessitate its repositioning. What worries us more is the morbidity of patients who develop ureteric strictures. When we plan to do RIRS without an access sheath or sheathless RIRS as we call it, there are three main challenges. Firstly, gaining access to the PCS or the pelvic calyceal system, maintaining low intrarenal pressure, and thirdly, removal of stone fragments. Of these, first and last are almost similar. The first challenge is to gain access to the pelvic calyceal system smoothly with less strain for the scope and the surgeon. The last one deals with removal of the fragments where we need to go in and out of the system multiple times, how to manage it with ease. This is just an extension of the easy access. Another challenge is to maintain a low intrarenal pressure. How to ensure a free inflow and outflow of fluid. Ureteroscopy is a basic procedure routinely done in all endourology units. Then why we need to discuss about sheathless RIRS? True, flexible ureteroscopes have lot of advantages over rigid scopes, like flexibility to manage the curvatures of the urinary tracts. But the problem is that it is meant for manipulation in narrow lumens and small cavities. Urinary bladder and urethra are not its ideal places. Many of you might have experienced this when you work in grossly dilated PCS and in grossly dilated and tortuous ureters. Secondly, the axial force we apply to the proximal end of the scope is only partially transmitted to the distal end. A significant amount of the force will get dissipated in other directions at the sites of bends or angulations. This will effectively place strain on the scope and produce kinks, adding to the strain of the fibers of the scope. To overcome these limitations and gain expertise in sheathless RIRS, we need to follow few simple steps. Expertise is nothing but standardization of fine details of a technique and meticulous execution with the precision. Now we will go into the standardized steps of this technique, which is nothing but a mix of basic endourologic techniques. But I had to perform nearly 100 procedures before I settled down to the present sequence, which was again internally validated and finalized. Gaining access to the pelvic calyceal system involves three main steps. 1. Gaining access to the bladder. Second, access to the ureter. Third is passage through the ureter and entering the pelvic calyceal system. We shall examine the techniques to do each one of these. The first step is gaining access to the bladder. First, you deflate the urinary bladder using a catheter. Then adequately lubricate the urethra. The flexible ureteroscope can then be introduced into the bladder just like a urethral catheter. This can be safely done without any visual guidance, but take sufficient care not to apply too much pressure. This is easy in female patients, but in males there can be occasional difficulties. What are the problems we face when we try to pass the flexible ureteroscope into the bladder just like a catheter? The ureteroscope is not as soft as a catheter and can get stuck occasionally. This happens in patients with high bladder neck and those with larger prostates. The solutions are very simple. Try to pass the scope under direct vision. If not working, pass a guide wire through the scope into the bladder and then slide the scope into the bladder. Even though both the techniques are fine, I prefer passing a guide wire into the ureter prior to the introduction of the flexible ureteroscope. This makes the urethra sufficiently straight for the passage of the flexible scope. Then introduce the flexible ureteroscope along the side of the guide wire into the bladder. This helps me in further steps also. Once you gain access to the bladder, the next step is to have access to the ureter. An empty bladder makes it easy to identify the orifice. This also avoids unwanted maneuvering of the scope in the bladder. Once you locate the ureteric orifice, pass a guide wire through the scope and introduce it into the concerned ureter. Then introduce a scope into the ureter over the guide wire. Though these steps look simple, many times we need to keep on maneuvering the scope in an attempt to locate the orifice and manage the guide wires. So let us look at the alternatives and the troubleshoots for this technique. Why do we have difficulty in identifying the ureteric orifice? We are doing ureteroscopies routinely and locating the ureteric orifices. Unlike a flexible cystoscope, a flexible ureteroscope is not designed for manipulation in a large space like urinary bladder. So let us see how to proceed if we have difficulty in locating the ureteric orifice. You withdraw the scope from the bladder and pass a guide wire through the ureteric orifice using a cystoscope or ureteroscope. This helps easy identification of ureteric orifice when you reach the bladder next time. There are situations where you find it difficult to enter the ureter even after passing a guide wire into the ureter. This is due to the narrow ureteric opening or the small caliber of the ureter. You dilate the orifice and ureter over the guide wire 2 French more than the size of your scope and retry. If fails, stent the ureter and revisit after a week. Now we will look at an alternate option. This is my preferred approach. Using a cystoscope or a rigid ureteroscope, a guide wire is passed into the ureteric orifice before the introduction of flexible ureteroscope. This helps in negotiating the urethra, easy identification of the ureteric orifice, easy access into the ureter, and easy access into the pelvic calyceal system. This method solves many problems in one step, and this is the reason for my preference to this approach. But there are few issues which needs to be cleared. What are the main problems we face with guide wires? The guide wire, which appeared as our savior in identifying the orifice and in passage through the ureter, this will start acting as a hindrance. This can happen very frequently, especially if you are using a guide wire which is rigid in its proximal part. Most of the guide wires are like this. The guide wire remains taut and block the movements of your scope. You need to maneuver the scope against the guide wire for a long time. This may be damaging for the scope, and we would like to avoid this. How will you manage the problem of guide wire hindering the entry of flexible ureteroscope into the ureteric orifice? There are two options. Pass another guide wire through the ureteroscope and gain access into the ureter. It is better to remove the previous guide wire for easy entry of the scope. The second option is for the more experienced surgeons. You keep the orifice in vision, remove the guide wire, and introduce the scope without any guide wire. This will also work because you have already located the orifice and you have kept the scope in the alignment of the ureter. The scope may pass in easily through the ureteric orifice. Both the techniques are useful. There is one more alternate option which can be tried. That is entry into the ureter without even a guide wire. But it has few limitations. It may be difficult unless we are dealing with a pre-stented or a patulous dilated ureter. You can attempt this after a ureteric dilatation. Even if the ureter is dilated, we may get stuck at the ureteric orifice. Unless it is a very grossly dilated ureter, the mucosa around the orifice will yield and may buckle, preventing the entry of scope. Passing a guide wire solves the issue since it gives fixity to the mucosa due to its stretching effect. Now the question is, why not we use a bi-wire, a wire with both ends are floppy? The problem is the bi-wire needs to be backloaded, which is a very cumbersome procedure. So multiple entry during a procedure becomes very difficult. In short, mastery of PCS access without a both end floppy wire or the commonly available bi-wire is an advantage in sheathless RIRS. Now we will move on to the next step, step 3. This is access to the pelvic calyceal system. Movement of the flexible ureteroscope through the ureter is often smooth with or without guide wire. But there are some situations where we get stuck. Let us see which are they. Guide wire, either through the scope or by the side of it, may hinder the smooth flow of flexible ureteroscope in the ureter. Why does this happen? Being flexible, the scope accommodates in the curves in the urinary tract, unlike a rigid ureteroscope. Friction develops between the guidewire and the scope at the bends in the urinary tract. The properties of the material of the scope also plays a role. There are two ways to solve this issue. Remove the guidewire and advance the scope under vision. Or you can withdraw the guidewire slowly while advancing the scope. This produces a counter movement which helps smooth passage. There is another problem which needs to be discussed. This happens when flexiscope is introduced into the ureter without a guidewire. The tortuosity of ureter amounting to sharp bends may cause difficulty in the passage of flexible scope. This can be easily solved by introducing a guidewire through the flexiscope and then advance the scope. With this, we have covered almost all permutations and combinations of problems in access to the pelvic calyceal system in a sheathless RIRS. The next major challenge is the management of irrigation. This is a problem in sheathless RIRS as well as in RIRS with access sheath. Irrigation with sufficient pressure is essential to maintain the visibility and to keep the system dilated. This helps in us to work freely inside the pelvic calyceal system. At the same time, increased pressure inside the pelvic calyceal system predisposed to sepsis. So we need to maintain adequate outflow. When we use access sheath, the system is decompressed by the outflow through the sheath. But the space for outflow is limited to the thin space between the scope and the sheath. The challenge of increased intrarenal pressure still exists. Our question is how to manage the irrigation in sheathless RIRS. There are two things to be done. One, keep the flow just adequate to keep the calyces distended. This reduces the influx of irrigant. Secondly, once the flexible scope is inside the renal pelvis, insert a feeding tube 10 French into the bladder to keep the bladder empty. Intermittent suctioning through the feeding tube also can be done. This keeps the pressure low in the bladder. By this technique, we have made the bladder a low pressure system since irrigant freely goes out of the bladder. So we can have a good side flow of irrigant from the kidney through the ureter into the bladder. Now the drainage is through the space between the flexible scope and the ureter, which is a distensible space. But the main concern is if the bladder ever gets distended, gradually pressure in the system mounts up and the drainage reduces. If you want to attempt a drainage of the bladder through a suprapubic route, through a cannula, that also can be done. But I haven't done this so far. Next important concern will be removal of fragments. Sometimes we have more fragments to remove. Luckily, the focus is now being shifted to dusting of stones, which leaves very few removable fragments. Even then, you might need to remove stone fragments in some occasions. There are two concerns in stone removal. One, avoiding the mucosal injuries. Second is multiple re-entry. Here, the scope needs to be kept in the center of the lumen to reduce the possible minor mucosal injuries due to stone or the instruments. This can be done if fragments are of appropriate size. Also, maintaining the scope in the center of the lumen of ureter needs some practice, as ureter has many anatomical curves. It is just like driving in a hilly road with bends. The second concern is multiple entry. This is a serious concern. We have discussed in detail about the initial entry. If every entry is going to be like this, then we have to say goodbye. But practically, it is not that difficult in most of the situations. The key is to maintain the alignment of the scope with the ureter during your entry and re-entry. This comes automatically with experience. When you are removing the fragments, make sure to dislodge the fragments close to the orifice immediately after exiting it. This makes it easy to re-enter. Hope you had gathered at least a few tips after listening to my talk. If not, I apologize for wasting your time. If you find it useful, practice it and send the feedback so that it is useful for me also. Try to share it if it is worth it. I have few disclaimers to make at the end. These are from my personal experience of around 100 cases, extrapolating basic concepts of endourology in Sheathless RIRS. All the techniques were used in one or many occasions, but no systematic comparison or evaluation was done. These are purely my personal thoughts, choices, and preferences.